everybody. My name is Daniel Kermany. I am currently an MD PhD student at Texas A&M Health Science Center, and I'm working out of the Translational Biophotonics Laboratory in the great Stephen Wong's laboratory in Houston Methodist. And today my talk is going to be on semantic segmentation of retinal OCT volumetric images. Unlike all the wonderful speakers we've had here today, I'm more going to be focusing on the data set size, as this work is more of presenting a resource for researchers to use, although I do demonstrate the value of this using a model as well. So I'm going to be presenting on eye pathology. And for those outside of the ophthalmology space, many people might say, oh, this is a relatively smaller problem than, say, cancers that can kill you or many other things that we've seen here today. However, while it's not a quantity of life issue, it certainly is a quality of life issue. And for many people, losing eyesight is considered to be a very huge disability and impairment to their quality of life. There's many surveys done comparing what people's perceptions are of different disabilities. In this chart, we see different votes people gave based on different ethnicities on what they consider to be the worst disability they can get. Blindness and losing eyesight tends to be higher than, in my opinion, I found it surprising, losing memory, Alzheimer's, and cancer even. There was a recent Reuters poll as well that surveyed people to see if they would rather have a severe disability or rather die, and 52% surprisingly said they would rather die than live with severe disability. Overall, eye surgery is actually one of the most common surgeries performed worldwide, with cataract surgery far outsurpassing any other surgical procedure. And about 4 million cataract surgeries are done in the US every year, about 28 million worldwide, and 16% of all eye surgeries, so about 300,000 surgeries in the US are retina-based, and about 7 million doses of intravitreal injections are given every year. So why would we want to increase automated segmentation of retinal imaging? Well, there's two main justifications here. One is this would help increase screening capabilities to many clinics that don't have specialists available who need to actually interpret these images and determine whether or not patients should get follow-up treatments. If we're able to do this autonomously, then the capability of screening many patients increases significantly. Most of these conditions are very easily preventable if caught early. However, when not caught early, can lead to irreversible blindness. On the other hand, there's a big push towards including intraoperative real-time OCT during operations, and as well as automating many different surgical tasks, such as LASIK and now cataract surgery, are being done more and more by computational systems. So having automated detection of sensitive structures becomes very, very important. So I'm going to give a quick overview of what OCT is for those who are not familiar. OCT is a optical-based imaging technique based on interferometry of the backscattered light. So simply put, you shine a beam of light into your tissue, and then you see what comes out, and then based on some interferometric techniques I'm not going to get into, you can actually reconstruct a 3D depth-wise image. So you can, shining a 1D light, you can get a 2D by scanning across your tissue, and then a 3D by scanning the other way as well. On the bottom left, I demonstrate what this would look like for a roll of Scotch tape. You can actually see into the tape and actually distinguish each layer of the tape with high resolution and it's very clear. So OCT's benefits are that you don't need to use labels or dyes. It's high resolution, real-time 3D, in vivo, and relatively inexpensive. So clinical applications of OCT outside of eye are pretty big. I'm not going to spend too much time on this, but applications range from gastroenterology in endoscopy, angioplasty, as well as dermatology. However, when it comes to the eye, traditionally, the way physicians have examined eyes is they look through the pupil and image or view the back of the eye and the retina, and it would look like something in the bottom left called the fundus. However, OCT gives us a way to actually see the different layers and into the retina itself. So you can actually see the layers as well. And on the right side, you can see what an OCT image of the eye would look like. Whereas the top layer, the top image, is what the front of the eye looks like, where you can see the cornea as well as the iris. And what it would look like for the retina is in the bottom left. That's what the retina and the optic nerve would look like in a cross-sectional view. So to give a little bit more context before I go forward, this is your eye. In the back of your eye, you have your retina and optic nerve, and that divot you see in the center over there, I'm going to use the mouse right here, that right there is your center of vision, and the OCT that you're going to be seeing going forward corresponds to that area over there. So the data set that we collected is pretty varied. It consists of normal retinas as well as an assortment of many common conditions such as diabetic macular edema, age-related macular degeneration, retinal vein occlusion. And in total, we've labeled about 530 volumes that have 19 slices each. So that corresponds to about 10,070 2D scans. So I'm going to quickly go over kind of what these images would look like. For retina with no pathology, it looks like this, relatively flat with a little divot in the center corresponding to your center of vision. In early AMD or just regular aging, you would see these protein deposits building up in the bottom of the retina, here in yellow. We also have conditions, another age-related condition, that as you age, the vitreous jelly of your eye starts to detach from your retina. And normally, this is a completely benign process, but in some, it actually does not want to let go in certain areas, and that's what we call an adhesion, and then when it actually starts to pull on your retina and cause tears, we call that traction, and that can lead to loss of vision and requiring surgery. Another condition that is relatively common is an epiretinal membrane that sits on top of the retina. On the left side, you can see it as this bright band over the retina, and on the right side, it's colored in as blue. So for this one, we've also, for each different of these one of these conditions, we have labels corresponding not just to the classification, but pixel-wise locations of where the pathology is. And for the final example here, I'm showing what diabetic macular edema, one of the biggest causes of blindness in the US and across the world, what it looks like cross-sectionally. You can see that there's fluid buildup inside the retina that should be flat. So I'm going to quickly discuss what model I use to kind of evaluate this data set to show that it is valuable and can show potential. We use the No New UNet or NN UNet. Many of you may be familiar with this. It was introduced in 2021 and to this day continues to be widely used and tends to be part of many winning solutions in international machine learning in biomedical images worldwide. It's based on just a regular UNet, but the innovation comes from the pre-processing where they actually set specific parameters, have specific data augmentation that's built to augment your data set, and it also includes 2D, 3D, and 3D cascade models, and also tries combinations and ensembles of these to come up with the best solution. And on the right side, you can see a sample of many of the different competitions that it has been involved in, the highest scoring competitors, including in many different modalities. Here we show a bunch of different CT images from different CT competitions. So this here demonstrates the performance that we've achieved on the normal images. On the top, you see the original OCT, In the center is the label itself that we manually labeled, and in the bottom is the predictions. As you can see, they line up pretty closely, and there's very, very few differences here. Now, we're still currently labeling all of the diseased ones, so unfortunately, I don't have those results to show for you today, but we're expecting to have all of those done and the data set ready to distribute to everyone by the end of next month. However, based on what we see here, the results are very promising, and there's no reason why we should expect a sudden decrease in performance when we add in the pathology images, considering how it's basically more of the same and nothing very brand new relative to what we see here. And to give a numerical representation of what we just saw, we can see on the left side the different models that the NNUNet trained and the different combinations as well, and the dice scores for each of, not just overall, but for each different label that is included here for the retinal labels as well as the pathological labels. In the normal ones that we trained, it seemed that the 2D model came out on top, but for some of the more complicated labels, it seems that the 2D plus 3D ensembles performed the best, and I would assume that when we add in the pathologies, the combinations 2D and 3D will prevail, because a lot of the pathologies actually show themselves much better in 3D, and sometimes it's not very clear in just 2D. And to validate this, we've also collected 5 publicly available external data sets that have a range of different conditions from different areas of the world, different points in time with different OCT machines. And we are also labeling all of these, and we're going to be evaluating our model with the pathologies externally to demonstrate that this data set holds potentially high value for researchers going forward. In conclusion, here we're presenting the largest 3D OCT segmentation data set to date, and we've achieved very high segmentation performance using the NNUNet framework on the normal images, and we plan to demonstrate this similar model performance across the common retinal and vitreous disorders, and we will evaluate the model using 5 publicly available data sets, and we will publish not just the data, but also the labels for our data as well as the external data as well, along with the code that we use to evaluate it. Thank you very much.
Thanks very much. Any questions? Okay, so just a couple quick questions. I was wondering, are you also releasing other metadata like the age, demographics, since it seems like it's highly relevant to the disease?
We do not have the age or other like demographic information of these patients. These scans were anonymized upon collection, so what we have is just the scans themselves.
Can you just briefly talk about how a clinician would use that information when they're doing these diagnoses?
Do you mean the segmentation information?
No, the things like age or demographic.
Right. In a clinical setting, when, for example, if a patient comes in with fluid in their retina, one of the considerations is definitely the age, because if they are 30 years old, age-related macular degeneration is out of the question. And if they don't already have a diagnosis of diabetes, it's probably a good time to actually test them for diabetes. And if that comes, this kind of goes into the workup of the patient.
Okay, I can ask another quick question. I was just curious, since I'm not familiar with OCT, can you talk a little bit about the variability in the quality of the OCT images? Is it like fairly stable? What's the noise statistics like?
Right, there is actually high variability depending on not just the imaging conditions, but also the different devices and techniques used. So OCT was actually first introduced relatively recently. I believe it was like 1991 was the first time it was demonstrated. And since then, the technology has progressed pretty substantially. So for older devices that we actually do show in our test set, the quality is pretty low. The resolution isn't quite as high. Whereas the newer ones have very high resolution and clarity. So there is quite a bit of variability, as well as when the image is being taken. As with most scans, if there's too much movement, you will have blurring and artifacts as well.
Okay, let's thank the speaker and all the speakers of the session. Thank you.